Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Understanding Failed Back Syndrome and Treatment Options for Spinal Deformity. The presenting provider is Trinity Health IHA Medical Group Neurosurgeon Todd Francis. Dr. Francis sees patients on the campus of Oakland Hospital. Welcome, Dr. Francis.
Very much. Welcome everybody. I'm going to share my screen here. Um, hope everybody can see the talk here. Talk today will be centered around failed back syndrome, deformity, and just general lumbar issues. I answered a few questions before this. I'll cover a lot of what you guys are asking in the talk. And then there'll be plenty of time after for any other questions we have. So I'll try to keep this quick and then we can get to questions. So we'll just do like a sweeping overview of this topic and just give you guys a better understanding about what this really means and failed back surgery syndrome and what can be done about it. Um, just a little bit about me. I'm the vice chair of neurosurgery at Trinity Health Oakland, leader of the Spine Center of Excellence at Trinity Health Oakland. I did my training Detroit Medical Center, Wayne State. It's neurosurgery, and then I did a fellowship in complex reconstructive spine surgery at Cleveland Clinic, and I'm a fellow of the AANS. Um, so I'm sure we're all familiar, and this may, ring true for a lot of you guys on the chat. Um, and I hear this all the time from patients and from online sources, et cetera, et cetera. Some people say, I love my back fusion, my back surgery. Others say they would never do it again. I'm in love with my spine surgeon. He's great. He did 7 surgeries on me in the past 2 years. Ridiculous. I mean, if any, general surgeon did 7 surgeries on your abdomen in 2 years, then some people would think something's wrong with that. Um, I had lumbar fusion. Surgeon says X-rays look great, but I'm still in horrible pain. So that's a very common finding, unfortunately, with back surgeries. And I can attest to this one. I went to 4 different spine surgeons. They gave me 4 different opinions on what surgery I need. Again, with surgery, I will say this, there's a lot of different successful approaches. So you may hear a lot of different answers, and a lot of them may give you the same results. Some surgeons prefer different approaches, but in general, can be, navigating this sort of thing is very confusing. Like, what's the right answer? Where do I go? That sort of thing. So hopefully I can present some, basic science to you guys that you can understand, so you can go into consultations more informed and about your own health and about the spine in general. So in general, I'm talking about lumbar fusions here, but in general, spine surgeries in general, you can include cervical fusions, um, or even just decompressions. Now, why do back surgeries in general fail? I mean, by fail, I mean, why sometimes do they not work to relieve your pain? And then that leads to this definition of this sort of failed back surgical syndrome. Um, so it refers to lumbar spine pain, low back pain of unknown origin, either persisting despite surgical intervention or appearing new after the surgery for spinal pain originally in the same location. So um, basically, it's either the surgery, you underwent surgery and you're in the same pain you were before, or you have new pain in the same area that they were working on, in the same location in general. So that's what that refers to. Um, Concerning is results of surgery in general. These are notes or figures from 2022 at the latest. So uh, prevalence of chronic back pain in adults is very, very high. I mean, 51 to 84%. It's one of the most common things that you present with to your primary care physician. Um, it's next to headache, maybe. Elective lumbar fusion volume in for a decade or so, 2004 or 5 to 2015, went up 62% in frequency. So more lumbar fusions in particular are being performed. Um, Anywhere, the figure of incidence of failed back surgical syndrome is anywhere from 10 to 40% of patients following back surgery, which is not low. Failure rates for lumbar fusion, pseudoarthrosis rates, 30 to 46%. It's almost half. In contrast, microdiscectomies, which don't involve fusions, just lumbar discectomies, Yeah, even those fail 19 to 25% of the time. So by comparison, in other fields, failure rates for an appendectomy in general surgery is 5% or less. Gallstone surgery, 0.1% to 0.7%, under 1%. Cataract surgery failure is 2 to 3%. So compare those numbers to the astronomical failure rates in back surgeries, and you're beginning to see the problem. Um, so I like to break down causes of this into three general topics. One being sort of the patient-centered reason, the other being the surgeon's reason, and then I would say, at the end, both post-operative and intraoperative reasons. Um, so one, the beginning, and this is all sort of centering on the surgeon trying to kind of see, who is a great surgical candidate and who is not so great of a surgical candidate. So it's our job to kind of weed out the patients that we don't want to operate on due to certain issues that will nearly certainly increase the risk, if not certainly lead to failed back, which is that's a baseline of psychological comorbidity, such as a baseline of major depression, uncontrolled depression, multiple prior surgeries, different pain patterns, and I'll get into that later. Um, an active workman's comp claim, an active litigation, auto litigation claim is has been in the literature. Like it or not, I mean, in the literature, it's been shown to lead to a higher prevalence of people not being happy with their surgeries. It's just the raw numbers. I'm not assuming anything or saying anything about that. Medical comorbidities are big, such as osteoporosis, uncontrolled diabetes, smoking. All of these medical comorbidities can lead to failure in certain patients. Intraoperatively, we as surgeons, sometimes they just don't do the surgery correctly or just plan and execute the wrong surgery, meaning a wrong level surgery, misplaced screw. It's a faulty execution of surgery or faulty planning, such as, pelvic parameters, which I'll go over, taking into account global sagittal balance in patients that are over, they're adults, not adolescents. Global sagittal balance, global pelvic parameters, and not taking a healthy um, account of this before surgery is planned. You can't undo fusion surgery, unfortunately. You can't remove the screws and make the joint move again. So this is sort of a move that's irreversible. So it's really, you got to really be careful planning it because you can't go back and erase it. And then post-operatively, there's different complications we can cover. The biggest ones that I'll cover now are pseudoarthrosis, meaning the whole point of a fusion is to take a joint, a disc, lumbar disc, an intervertebral disc, scrape it out, put a cage, bone, metal, plastic, something into the space that can form a conduit for your own bone, much like a broken bone, to grow through. We put a little cadaver bone in there as well. So the bone grows through that segment, and eventually you'll become one big fused vertebrae. L4, L5, for instance, becomes one immobile vertebrae. If this process fails, and it may fail, that's called pseudoarthrosis. Um, Adjacent segment disease happens around level of your previous fusion. So when you become one big block vertebrae, you alter the biomechanical nature of the spine. And if you don't move at one level, the stress of that level is passed on to the adjacent levels above and below it. So, for instance, if L5S1 gets fused, the L4-5 level directly above it becomes the bottom of the spine. And everything below that is solid bone. So there's a much greater pressure on that L4-5 segment, whereas before it shared that pressure with the L5S1 segment. So biomechanically, there's a lot of stress, and it can lead to future problems down the road. Um, so we'll cover some preoperative factors such as, um, preoperative psychological issues, against anxiety or depression, especially depression, is the strongest association with failed back syndrome. So, pain signals are altered in depressed people. Your response, your recovery from surgery is definitely longer and prolonged response to medication, pain signals. They're all sort of magnified if you have uncontrolled depression. Patients with a history of multiple back surgeries, of course, are at a higher risk because trying to fix a failed back surgery like a pseudoarthrosis isn't always perfect. Multiple levels of surgery. Now you're having to do more complicated procedures to try to fix it. If there's a global imbalance, that brings comorbidities. So much higher risk if you've had multiple surgeries. But it doesn't mean we couldn't help you. But I got to know if you had several back surgeries, you're at a higher risk of more failed back surgery. Um, so basically, if you happen to be, have an element of depression, we do screen for that. And if you're getting seeking help for and getting controlled, depression controlled, it's going to be a much better prognosis for you preoperatively. Um, Medical reasons are the big ones. Now, we in the spine center, we weed out all these via, pre-op testing. So we measure your A1C levels, and now that level actually it says 8 there. Now we do, uh, you know, um, we do 7.5, and some practices even go down to 7, below 7 for A1C levels. Anything really above 8, it's been shown in the orthopedic joint literature to definitely lead to wound infections. So that's another reoperation and a big prolonged problem we want to avoid. Osteopenia or osteoporosis, compression fractures, weak bone leads to failure of the hardware, screw pullout, cage subsidence, failure to fuse. Pre-treatment, if you're a candidate for with Forteo or Prolia for even 4 weeks, I know it's like a year-long process, but even 4 weeks of treatment preoperatively has been shown to reduce the risk of failure significantly. So that might be something that you may need. Smoking has absolutely a contraindication in elective back surgery in that it leads directly to failure of the bone. So nicotine is a vasoconstrictor. It prevents neogenesis inside the disc space. New vessels kind of bringing pro osteoclastic factors into the disc space to build bone, and that can lead to failure. So I make my patients be nicotine free 4 weeks post-op and hopefully thereafter. Again, anything like medical, such as a heart disease, prior low ejection fraction, previous heart attacks, coronary artery disease, COPD leads to a significant surgical risk intraoperatively, and you'll need clearance from your primary care doctors or your specialists. But it's a direct correlation to how long the surgery takes, and typically, fixing a failed back surgery can take longer than a typical surgery initially. So, that can you can tie in there. So. Again, I went over this already, but uh, you know, interestingly enough, economic compensation influences. This study from 1999 showed that the economic compensation, such as lawsuits or whatever, influences outcome in lumbar spinal surgeries, not in cervical spine surgeries, which I found interesting because I don't know what the difference would be. But either way, so all of these affect the outcomes. All of these affect your satisfaction with surgery, your recovery, and it's for a host of reasons. So it's uncontrollable. It just is what it is. Just thought I'd throw it out there, but it's something we consider. Um, Intraoperative factors, the second thing that we kind of look at. And so here we kind of can talk about how, a snippet of how surgeons plan or should plan for these surgeries. Okay, so your body, and the group we're talking to here, I'd say average age on whatever it is. It's not adolescence, that's for sure. Probably 60s, 50s, 60s. As we age and become skeletally mature, the sagittal plane, which I'm showing you right here, looking at you from the side, that is really the plane that I focus on more. Not so much the coronal plane, turning and facing me. That's more of an adolescent scoliosis kind of problem. In general, most adults are balanced coronally. It's the pitching forward of the body, leaning forward, loss of lumbar lordosis is what we are concerned with as far as our parameters mainly. And this sort of this cone of economy from your feet up to the floor, and that anywhere in that red area, your spine can deform, and you'd be happy. Anything sort of out of this area, you will have to compensate with your butt, your legs, your pelvis, your knees, leading to leg pain, back pain, and unhappiness in general when you were trying to walk or bear weight. So, restoring this natural sagittal balance surgically, or maintaining it if you already have it, is something that is of utmost importance to the surgeon. Not following these guidelines leads to failed back surgical syndrome. So this is basically a SVA, sagittal vertical axis drawing in the middle there. It's measured, I measured actually up a little bit higher with the neck. It takes into account cervical lordosis, but classically it's measured from C7, plumb line drop down, that's cervical vertebrae 7, drop down perpendicular to the floor. That should intersect the back of the sacrum, as you're seeing right there in that black line. That's normal sagittal balance. Now you see on the right, if you were to flatten your lumbar spine out, either through degenerative changes in the disc, your spine sort of loses its normal curvature that you see in the middle, you're going to pitch that line forward. And that's going to be forward of the back of the sacrum, and that's going to cause a lot of problems down the road. Now, um, your Cobb angle, which don't know if you can see the arrows here, but basically Cobb angle is the angle between the sacrum and the L1 vertebral body. So that should be on the order of about 50 degrees. It should match your pelvic incidence, which we can measure on your X-ray. It's the angle between the sacrum and the hips. So if those mismatch, meaning if you've lost lumbar lordosis, your pelvic incidence is a constant. It doesn't change more than a degree or two here and there. So if those mismatch, you over 10 degrees either way, you will have a problem. You'll be unhappy and you'll be out of that cone of economy. Flattening the back with surgery leads to all kinds of compensatory mechanisms for flat back syndrome. As you're seeing here, you increase your pelvic tilt to, as showing A, B, and C, the angle between your femoral heads and your sacrum in a perpendicular line. As you see, your pelvic tilt from left to right is increasing as you rotate your pelvis to try to bring your head back over your sacrum. Your legs, pelvis, knees, hips have to compensate for this, and over time, that really hurts. No one wants to walk around like this person. So, for instance, here's an example. There's a sagittal view of a scoliosis X-ray. You can kind of see the line. Here's the neck up here. Like where you say C7. If you were to draw a perpendicular, look where it's supposed to be back here. I don't know if you can see my arrow here, but it's supposed to be somewhere around the back here, and instead it's running well forward of that. And this is someone normally standing up, and you're seeing how much this person has to compensate to bring their body back here, despite all this lovely surgery here and you know, um, uh, back here, yeah, despite all the lovely surgery here, it's sort of failed to kind of fix this. And after a corrective surgery, and it's no simple feat, but after a corrective surgery, lumbar lordosis is restored, and you're seeing much better balance here of the neck over the pelvis, much happier, much more. It's not perfect, but it's definitely within the normal range. So that's corrective surgery right there, and that's why this failed. So it's a loss of lumbar lordosis and pelvic parameters. So example here, just a broken rod, failure to fuse, and flat back. See, it's just one straight rod there, no inner bodies, no cages, no nothing. It just sort of flattened out. This is their sagittal, vertical axis. Look how positive it is. This is where it should be. It's way positive, and then they have to compensate by trying to tilt their pelvis out. And with surgery, eventually, that corrects out. I mean, it's better. It's not perfect, but now you're seeing adding lordosis here. Um, Now you're looking better in balance. Same thing here. I mean, in this case, it's more of a kyphosis of the cervical, the thoracic spine that has caused the problem. Lumbar lordosis is okay, but here above the level, so the adjacent segments to the fusion are going bad. You have this sort of kyphotic deformity of the thoracic spine, and that also is fixable. So that's almost perfect balance right there. So there are corrections we look at as a surgeon, just kind of see, some of the X-rays we look at are shockingly bad, and you can see if you feel like yourself pitching forward, you might be suffering from that problem. So, and these surgeries, of course, to try to fix this in a case of already a pre-fused spine, lumbar osteotomies, pedicle subtraction osteotomies that I'm showing here are quite, complicated surgeries. They involve almost some sort of complication, blood loss, CSF leak, weakness, numbness, new numbness. You're working too close to around nerves and doing too many violent maneuvers around here. I mean, you're basically cutting a wedge in this bone using a chisel, to try to get lordosis, get correction here. You see all the kyphosis here. You cut a wedge out and fold it back on itself to get that lumbar curvature we're looking for. It's really a very violent surgery, not one I frequently choose to do, but if needs to be, it's done. Not simple. But this is the problem here. That's why, if you've had multiple surgeries before, this is kind of why it may lead to more failed back. And of course, uh, pedicle screw misses happen. This is sort of egregious, but this is sort of just completely missing the bone. They're supposed to be placed here. Sorry, supposed to be placed in the pedicle here. These are way outside, sitting in the chest cavity. the lumbar cavity. So misplaced. I mean, any of these techniques, it's very technical. Failure to remove all the disc when you're putting a cage in, wrong level surgery, intra-op nerve injury. All of these things do happen, but they can all lead to this back surgery basically not working. These screws aren't doing anything here. Might as well not have put them in. They're in soft tissue. So I mean, that's just whatever is fusion there. This isn't bearing any weight. These pedicle screws. So this is whatever this is going to fail. Flat backing patients with kyphosis. Misplacement of cages. Any of these can lead to failed back. I mean, just inferior constructs. I mean, people that just put pedicle screws in, they don't pay attention to lordosis. Flat back people with a straight rod. I mean, this is all faulty technique, and it's on us to try to avoid this. Um, and then post-operative factors, we get into like, I mean, why, and this is more of the questions you guys were wondering about. Now, why even fuse in the first place? So this is like, what are we trying to achieve in the post-operative period to make you better? Why do we fuse you? Why don't we just do a laminectomy? Why don't we just decompress? Well, there's really several reasons for that, and I'll break it down to just a Givens functional spinal unit, two vertebrae, a disc, and all the intervening nerves and ligaments and joints, including the facet joints in the back. There's two of these that contribute to one functional spinal unit. Failure of this functional spinal unit to do its job, which is basically bear the weight of your torso and head and arms, if you're talking about the lumbar spine, and transmit nerve impulses from your brain to your legs. Any failure of that leads to problems that your body will let you know: back pain, radiculopathy, nerve pain, you know, uh, anything that you experience. Your pain, numbness, weakness, whatever, is a reflection, usually if it's degenerative or deformity based, the failure of the functional spinal unit to do its job. So um, we like to call this a dysfunctional motion segment. So basically, the disc, the black disc here, as you see, look at the difference between this disc here and the rest of the remaining normal discs here. You're going to see a big difference in appearance. It lost its water, it lost a little bit of height, there's bulging out the back, impinging on nerves, and the water content's very decreased, so the springiness is less, and you're less able to bear weight. And then you get pain because every time you bear weight on that, the bones move in a way that they're not supposed to move because the disc doesn't work. The bones erode and grow these spurs on them, these traction spurs, bone spurs, you've heard that, and bulging discs, you've heard that. So degenerated disc segments here are, and this is a gross section of a cadaver, and you're seeing the difference between a healthy disc and one of these that's degenerated. Um, Fractures or defects, such as a pars defect that you see right here in this CAT scan, a defect of where the facet joints lock up, can lead to spondylolisthesis, so slippage of one vertebral body on the other. And if you can see my arrow here, there's a nice straight line. Then there's this step off here, and this is allowed to slip forward on this level. Every time you bear weight, the nerve root sits in this little pocket here. Every time you're bearing weight, this wants to go forward, this wants to go back. Nerve root gets trapped in between. One or both legs hurt you. Every time you bear weight, when you lay down or rest, you sort of get relief. When you get up and you're active, it starts to hurt. Low back, dense central low back pain. That's a very good picture of a dysfunctional motion segment, okay? Herniated lumbar discs, so discs that squirt out and push on nerves, cause radiculopathy. That's sort of what this sciatica. So if a nerve is impinged by a herniated disc, that causes a shooting pain down the leg and a well-known distribution based on which nerve it is that's affected. So L1, L2 is sort of your groin, L3 is your quad, L4 is to the shin, L5 is the big toe, top of the foot, and S1 is classic sciatica, buttock, back of the leg, hamstring, calf, and bottom of your foot and heel. So any one of those nerve roots impinged by a herniated disc gives you a pattern of pain that we can kind of predict, and then we back it up with an MRI. Um, Kyphoscoliosis, so basically like a segment that rotates and curves because the disc is so shot, your body is trying to remodel everything, and it ends up inducing scoliosis at a certain level. That just degenerative scoliosis, that's a big problem as well. So all of these sort of problems you factor into diagnosis. So you look at a film, look at what you're presenting with, and then we come up with a diagnosis of what you have. Do you have a herniated disc? Do you have radiculopathy? Do you have a dysfunctional motion segment? Do you have signs of a central agonizing back pain? It's due to a dysfunctional bad disc. All of these kind of factor into what we would offer you for surgery. Um, Lumbar fusion is a good treatment for a dysfunctional motion segment. So, if a disc does not do its job properly, in that it doesn't bear your weight properly, or there's a deformity such as a spondylolisthesis, okay, and every time you're getting up, the spondylolisthesis worsens. So there's dynamic translation on an X-ray. If you bend your flexion extension X-ray, I'm sure some of you have had those where you look and you're bending forward and it does this, and you're bending backward and it reduces back there and it's moving every time you're up. That's different than, say, a stable spondylolisthesis that does not move when you bend. That's more amenable to, say, maybe a more conservative surgery. Whereas if you have dynamic translation or motion when you're up on an X-ray, that is almost invariably going to be recommended to be fused. Um, and what fusion does, basically, you just go in there, any approach from the front, side, back, whatever, remove the disc somehow using a big curette scraper. You remove the intervertebral disc, replace it with a structure such as a cage. This is a cadaver bone. I use an expandable metal cage or a static cage from the front, a big wedge. That's a hollow wedge that allows bone to grow through it, and you fill the rest of the space with cadaver bone and grow your local bone if you have any. If we harvest some locally or some growth factors such as a bone morphogenic protein graft that helps bone grow. You fix it down with some pedicle screws, which you see there. That's going to make it not move like an internal cast or a brace. And then basically that creates one functional spinal unit, one big bone that doesn't move. It translates this mobile unit into one big bone that does not move. And now you're going to see this becomes the bottom of your spine now, L4-5, and there's more pressure on top of that. But at this moment where you had previously translation or if you had a spondylolisthesis or a bad disc, now all of a sudden there's no more movement here. No movement means no pain. There's no arthritis, there's no inflammation, the body doesn't read that as a problem anymore because there's no dynamic translation, there's no more bone hitting bone. It all feels a lot better and your back pain goes away. And once this matures from 3 months to 2 years, you will notice no more back pain. So fusion in this sense is quite good. It has good results. Fusion for, say, a non-spondylolisthesis black disc like this is not as good. It's sort of 50-50 if it's going to help you or not. If it's convincing that you have a lot of what's called modic end plate changes, meaning like there's inflammation in the end plates, bone spurring, flat disc, it's almost bone on bone, that's going to bode much better than this patient right here that has just a tall black disc. That I'd say is not as good of a prognosis as someone with a worse deformity if you're going to have a fusion. So um, now, when things fail, typically you'll know it, okay? And so you have surgery, you have a fusion, for example. Horrible back pain before, you got better for, say, anywhere from a few months to 2, 3 years, 4 years, whatever. Usually 2, 3 years, and then your back pain returns. It's kind of the same area, kind of the same pain, this dull backache. Maybe you hear some clicking sounds. Maybe you feel things rattling around. Maybe felt a pop at some point, think your rod broke. A lot of times people say that. I bent over, I felt a pop. That is a sign of pseudoarthrosis. Now, these screws and rods we use are titanium alloy. I mean, they're extremely strong. If they break in half, for instance, that is not, oh, I had a trauma or, oh, I fell or bent wrong. That is a sign that this fusion failed. Now, if this here does not fuse and this moves, there is no more disc in there to help cushion this area. So now the only thing holding your spine together basically are these screws and rods. Every time you get up, every time you go down, that cycles stress on the rod. Up and rest, up and rest. That cycles stress on the rod and screws. One of two things is going to happen. I don't know if there's any carpenters in the audience that put a wood screw through a faulty joint that's moving. What is the wood screw going to do? It's going to telescope out or it's going to break in half. Um, this is this is the stress strain curve, for instance. I mean, the more load is on these metal screws, it reaches a point where it deforms and then fails. So basically, it's going to bend as much as it possibly can to a point of failure, and then it breaks. That's this curve right here. This is where the screws sometimes they don't break, but they just wiggle or toggle out like wood screws would. So there's bone is sort of kind of this is the bone sort of remodeling around this. Look, the screw isn't in anything right now. It's not in bone. It's in soft tissue right now. It's just sitting in a cavity of bone. I see lots of patients come into my clinic. Oh, my surgeon said I can't help you. I get a CAT scan. I see this. I'm like, my God. I mean, that's extremely painful. These screws are moving around every time there's nothing keeping these screws in there. Every time you're moving around, these screws are wiggling and hitting the bone. That's extremely painful. Um, this right here, I mean, look, this clearly failed. Rods broke, both rods broke. This clear failure here. You get a CT scan, you look at this. I mean, there's absolutely no bone growth across these levels. The end plates are all jagged. They're not even and smooth. They're clearly there's the bottom of the body's been trying to remodel this. It's been building bone up in here. How this bright white signal you have here as opposed to this, compare the two. Very bright white. That's all bone that the body is trying to remodel. There's all Wolff's Law and Hooke's Law that describe this, like points of failure and end plate sclerosis. And the body is using Wolff's Law is trying to remodel the bone in areas of stress. And that's what you're seeing here. There's absolutely no bridging bone across. There's no growth of bone across of your own. And basically, there's nothing holding the spine together besides the screws. And they will fail at some point. Just a matter of when. Um, so what happened? Okay, so surgeon fault, yes, sometimes. Bad patient selection. You try to do a multi-level fusion in a smoker who smokes a pack of cigarettes a day, or someone has raging diabetes, uncontrolled with a hemoglobin A1C of 10, or someone has horrific osteoporosis and compression fractures. You try to fuse that person, they're probably going to fail. Faulty technique. Did you remove all the cartilage? Did you just kind of, you know, do a half-ass job and kind of remove a little bit of it, shove a cage in there and call it a day? Oh yeah, you did the surgery really quickly, but all the cartilage remaining in there is going to lead to failure. Did you choose a bad construct? Look at this. I mean, I don't know what the heck this is. I mean, that's not dealing. This is your interlaminar spacers. I mean, these do nothing. These induce flat back. This person skipped a level. I mean, it's screw there, cut out the middleman. I mean, these are going to fail because there's still motion in the middle here where the grafts are. I mean, it's just ridiculous. And on the patient's end, if smokers, diabetics, osteoporotics, I mean, that stuff's got to be under control. So as a patient, you got to kind of do your part in this process because all the three of those things, diabetes, uncontrolled osteoporosis, or smokers, will lead to problems such as pseudoarthrosis. Um, so what do you do to fix it? So first thing is get the failed hardware out of there if you can. So remove anything that's loose or broken or whatever, recycle the hardware because there's already wear on it. Get it out of there. So the interbody devices that aren't healed, you got to get everything out of there. Then scrape whatever you can of the end plates, get some blood flow in there, and then reimplant the new hardware. Get a new cage, do disc prep, whatever you got to do, just reimplant screws and get, as you see here, a before and after picture here. So there's pseudoarthrosis here and here is subsidence. You see here, this cage is basically sunk into the end plate there. And what do? You get a new cage in there, bigger one, expandable one, perhaps. Get one in there to kind of fix that. So that's what you do to fix it. So as you're seeing here, well, why, going back to the first slide, I mean, why you say, oh, well, some people say it was the greatest thing that ever happened to me. Some people say, well, I'd never have it again. I had one and then I needed another one and then I need another one. Or it's even the more confounding thing where people say, like, oh, yeah, he was great. He did 4 surgeries on me, I had lumbar surgeries. It's great. Well, I mean, here you go with previous fusion, adjacent segment degeneration, a big disc herniation, adjacent to this, and here's a one level fusion. And sure enough, now you're going up one more level and one more level, So as you go, this fusion here, bad disc here, you're putting a screw above there. Guess what's going to happen to this level? That's going to go bad, and you're marching up the spine like crazy. So my old fellowship director used to say spine surgery begets spine surgery. So that's why as surgeons, we got to really be careful about who we recommend for surgery. It's we're cautious about it. So if we tell you you don't need it, it's a good thing. It's not a bad thing. Okay, so if you don't need spine surgery, that's really good. You don't want this if we feel it's not going to help you. Having this can oftentimes lead to way more problems than you not having this. So, again, always keep in mind that it may not be a bad thing if your surgeon tells you you don't need it. So, is just a montage here of kind of progressive. This is say 1 month after surgery. Here's about a year after surgery, and here's 2 years after surgery. Look at the adjacent level. How much retrolisthesis there is. It's starting to go back. Less disc height than here. More end plate sclerosis. You're seeing this is a sign of adjacent segment disease. Now again, this person may have done fine. If they didn't have a lot of pain, that's fine. We just look at it radiographically and say, okay, great. Just go on your normal life. If they have pain from this, it's adjacent segment disease, and something needs to be done about it. Um, So this is just the fact that biomechanically, this is now taking away a lot of this stress at this level and passing it on to the level above it and around it. So you develop, what do we develop? We develop motion sparing implants. Now I don't use artificial discs in the low back because I don't feel that the numbers really are that great with them. I feel they fail a lot. They're hard to revise. But there's a lot of surgeons around that do artificial discs in the lumbar spine. I do them in the cervical spine all the time. They're really well proven. There's a lot. We're on several generations out from the initial implants in the cervical spine. There's a lot less force on those discs. They do really well. Lumbar spine, not so much. But we've tried everything in the lumbar spine, at least as far as since I started studying spine surgery, flexible rods, shoelace rods, um, mobile systems, in situ fusions with no rods. They all sort of have failed. So adjacent segment disease remains a big problem. Now, a lot of the literature coming out now says that, well, you know, uh, pelvic parameters such as, like getting good correction here, not flat backing somebody, getting good lordosis through your constructs prevents adjacent segment disease by restoring normal anatomy, normal lordosis. So good technique can lead to reduction of this. And adjacent segment disease, it's reported anywhere from 5 to 10% after these surgeries. So it's not like it's very frequent, but in general, it does happen. So the biggest question is like if you're facing a fusion, like a lumbar fusion, do you really need it? Now, the question is like number one, what are you complaining about? That's the best thing. Do you have a nerve pain in your leg mainly and no back pain? Do you have only back pain or do you have both? Do you have central back pain that's sort of agonizing and sort of this pattern of hurts, doesn't hurt, hurts, doesn't hurt? I'm getting up, sitting down, getting up, sitting down. I'm fine during the night when I'm laying down. I get up around 10 o'clock. I got to take a rest or sit down in a chair. You know, um, that's a sign that you have a dysfunctional motion segment, a bad disc, spondylolisthesis, something like that. Spondylolisthesis can cause radiculopathy by the fact the nerves get pinched too. So you might have both. Or is it just a shooting pain down the leg? That's more treatable, more predictably, and usually with a less invasive type of surgery. Um, have you exhausted conservative measures? So people come in with a week of pain. Well, you definitely don't need a fusion at that point. You need physical therapy, core strengthening exercises, pain management, injections, medications, blocks, that sort of thing. There's all kinds of new technology out there that can help you. It's this non-invasive or minimally invasive and doesn't involve fusions or surgeries. Um, a big example is the intercept procedure. One of my pain doctors does that, where they can burn a nerve inside the bone itself that helps with back pain. So there's a lot of other conservative measures we can do that don't involve surgery. Then if you come in, what do your imaging studies show? Is there a deformity? Is there a spondylolisthesis? Is there scoliosis? Is there, spondylosis? So basically, is there signs of motic type changes in the end plates, loss of disc height, flattening of the disc, bulging disc, traction spurs, spondylosis, or someone mentioned spondylitis, same kind of thing. Is there evidence of that the motion segment's not working properly and your body is trying to fix that? If there is, then you may be amenable to a fusion. How are your comorbidities? Are you a raging diabetic who smokes 2 packs of cigarettes a day, is obese, and has terrible bone? Probably not going to get a fusion at that point. Not an elective one at least. Um, Quality of life. This is a question only you guys can answer. I mean, are you willing to undergo a somewhat risky procedure because your life just basically sucks? I mean, you can't do what you want to do. You can't play with your grandkids. You can't go to the grocery store. You can't get out of bed in the morning. I mean, that's that. And then it's definitely at that point the benefits would definitely outweigh the risks at that point of this surgery. So here's an example. So this person presents with, horrific leg pain in one or both legs, with back pain, not so much. It's all in the buttock, down the leg to the back of the calf. This is a L5S1 disc herniation with S1 impingement. That's amenable to just a laminectomy and a decompression or like a discectomy, some small outpatient surgery. There's no to minimal to no changes in this disc. It's well aligned, a little bit of a bulge, but there's the herniation. There's no real spondylolisthesis, minimal end plate change. This person does not need a fusion. They need a discectomy, a decompression, fusion down the road if needs be. This person has a spondylolisthesis. You see now a nice even line and then the step off. This is an isthmic spondylolisthesis with pars defect. So there's a defect in the back here that allowed this to kind of slip forward. Sclerosis here, almost bone on bone. This is almost autofused in this situation. There's so much inflammation here. The body has almost created a fusion for this person off the bat. This is the nerve root. I don't know if you can make that out. Just kind of caught in between the pedicle here and the bone. A lot of back pain here. So this person might need to get in there anteriorly, open this up, reduce it, and get decompressed possibly. So this person would definitely need a fusion. This person would not. So that's kind of a rule of thumb. Again, I'm being very simplistic about things. So there's also those patients out there that had several surgeries, but you hear kind of, well, I don't think more surgery can help you. And it's usually kind of shocking to a lot of patients and, a lot of anger and sadness and that sort of thing, because unfortunately there is no magic wand in spine surgery. We we adhere to basic principles that we learn, and sometimes more complex principles that we learn. And sometimes there's just, we just not getting the information from the patient or from the x-rays or whatever, that we need to say, okay, I can fix this. Sometimes you just can't, and there's other reasons why. For instance, a patient with intact fusion. So all the constructs look great. There's no broken hardware. There's no loose hardware. There's no pseudoarthrosis. That's fine, as long as, number two, spinal pelvic parameters are within normal limits. If your construct looks great, your screws are great, you're fused in a flat back position, pitched forward, that is amenable to correction. Whereas if your spinal pelvic parameters are normal, good lordosis, your head's over your pelvis, you stand up straight, then you're in balance and you don't need to really fix that. You can't fix that. Yet you're still in back pain. So why is that? No one really, unfortunately, knows why. Um, a lot of it just is a fact of like poorly understood chronic pain signals in your spinal cord. Like for instance, dysesthetic pain, burning, CRPS type symptoms. Like my limb just is on fire. My leg is, my hand is. A lot of orthopedic surgeries kind of cause this. A lot of spine surgeries cause this. Non-anatomic pain. My whole body hurts. Both legs hurt everywhere. Front, back, sides, everything. There's no dermatomal pattern to it. Again, and the bottom two questions are important too. Still, what's your quality of life and are you a good surgical candidate? So, a lot of the reasons here, if this checks out, you don't need surgery at that point. So, what do you do? So, number one, you look for alternative treatments. Number one would be a dorsal column stimulator trial. Now, I'm sure you are familiar with this. It's a little implantation that goes in your butt there. It's like a stimulator leads that go up the spine, the thoracic spine, about T10. It can modulate pain signals in the dorsal columns of your spinal cord using low amplitude signals. It's very successful in a lot of patients. They have a stimulator implanted and their back pain's controlled. It's a lot better. There's chronic pain programs, CBT therapy, alternative medications, acupuncture, pain specialists, different medications, weird medications you never heard of that control pain, that, typically an opiate wouldn't control. If you're osteoporotic or if you have comorbidities, control diabetes, get a bone health consultation, see neurology and pain management, and maybe your comorbidities you can get over, quit smoking, you become a surgical candidate at that point. So there are alternative treatments. No one should tell you, well, I can't help you, go away. There always should be considerations from the next step, like spinal cord stimulation or some alternate type of therapy to recommend. So, in summary, failed back surgical syndrome is ongoing low back pain despite surgical intervention. The failure rate for lumbar fusion surgeries is significantly higher than other surgeries, and significantly higher at that point. Risk factors, we talked about preoperative issues such as medical comorbidities, psychosocial factors, intraoperative, usually surgeon problems such as faulty planning, faulty execution, and then postoperative problems such as failure to fuse, pseudoarthrosis, and adjacent stemmer degeneration. Best question to ask ourselves is, do you need a fusion or not? Do you need what surgery do you need? And a lot of that is up to your surgeon and you to talk about options. Radiculopathy, like where is your pain? Radiculopathy down the leg, only with no back pain, usually is amenable to just a decompression of the nerve that's affected. Whereas a low back problem, such as a dysfunctional motion segment or a low central back pain, is more amenable to fusion. Have you exhausted physical therapy, chiropractic, conservative measures, all this stuff? Are you a good surgical candidate? How's your quality of life? Big questions we have moving forward there if you really need a fusion. So there's always other options to do as well outside of that, if surgery is not, if reoperation is an option for you. So that is the end of my talk. Happy to answer questions if you guys have them.
Okay. Yes, absolutely. So I'm going to shift here. Okay. So we do have several questions already in the Q&A feature, but if you haven't asked your question yet and you do have one, please drop it in to the Q&A feature at any point here and we will dive right in. So what can be done for spinal stenosis? Cannot stand without a lot of pain. What about a patch that might stop the pain from reaching the brain?
So that's a great question. So spinal stenosis is an interesting condition. I did not cover this. So spinal stenosis is one of the most treatable problems we have as spine surgeons. So that is for lay people, basically the canal. I can go back to my slides here. So, uh, so let me go back to say a picture um, of the spinal. So here, the nerves all run down this canal here. Okay, all of them do. They all come out at each foramen, L1, L2, L3, L4, all come down to form the sciatic nerve in your hip, goes down the legs. So if there's a narrowing of the canal itself, the spinal canal centrally, causing impingement of multiple nerve roots, you're going to get this whole thing that you're describing. I can't stand up straight. I got to lean forward on a cart to walk. I got to, I go walk for a while upright and I can't lay flat. My legs burn like I ran a marathon. They ache, they get tired. I got to stop and bend forward. That is due to spinal stenosis. Most of the time, 90% of the time, that's amenable to a simple laminectomy, where you just remove the spinous processes and the lamina back here, opening up the canal, allowing the nerves to open up. And typically that gives immediate relief of this problem. Now you're going to be deconditioned down the road because you haven't walked a lot. So your physical therapy will help you, but you'll notice that you can walk much further distances without having to stop every 5 seconds or use a walker. So I do a lot of spinal stenosis surgery, and that if you have true spinal stenosis, that really helps. Now, if the spinal stenosis is in a setting of a spondylolisthesis, that may require a fusion. But again, 90% of the time I see this, it's just a laminectomy. It's a pretty straightforward surgery, 1 or 2 day stay in the hospital, usually a 1 day stay. If it's a one-level laminectomy, it's an outpatient surgery, and typically we get great results with it.
Okay. So someone is asking, is it possible that the use of THC prevents fusion from occurring?
There's been a lot of research on this recently. I do not, as far as I know, I do not think that THC affects fusion rates. Now, again, more research is ongoing, but I do not find any evidence that THC has a nicotine type effect. Nicotine is the worst for fusions, but as far as I know, as literature now, there is no signs that THC, at least as far as I'm concerned, inhibits fusion.
Okay. This person says that a family member of hers falls a lot, and the doctor says it's pressure on the nerves in the low back area. He's recommending to fuse the low back spine, but she doesn't have back pain. So she got a second opinion, and the second opinion says don't do it. Do you have an opinion on that?
Um, where was this written here? Let's see.
Yeah, so it's one of the top questions, one of the first ones asked early on. And again, so she's saying that there's a lot of falls happening because of pressure on the nerves in a low back area. Is that something that can be fixed by fusing the low back spine?
Don't see this question. Um,
So I think it's like the fourth one down.
Under answered or open?
Open.
Got it. I see. Falls a lot, doctor says, because pressure on nerves and low back area. So, okay, so kind of a general question there. I got to see the films. So, why are we falling? Is our legs weak? Do we have a foot drop? Do we trip? The nerves not working, muscle not working? Fall because of you have a pain attack and fall to the ground? Um, if there's pressure on the nerves in the low back area causing muscle weakness, like a foot drop, causing you to trip and fall all the time, and if you take a look at the film, there is a deformity there impinging the nerve, such as a spondylolisthesis or a scoliosis that causes nerve impingement, then yes, fusion may help, despite the fact that you may not have back pain. Now, it may very well you may not have back pain, but if there's an underlying deformity there that happens to not cause pain, but is causing nerve impingement and weakness, your surgeon may opt to say, well, I can't decompress this safely. If you remove this facet joint out here surgically, you're going to destabilize the spine. I better fuse you. Yes, that may be a reason. I'd have to answer this question about you specifically. Or your sister specifically. I'd have to look at the films. Welcome to come see me, and I'll take a look and give you an interpretation of that. Without films, I'm kind of can't give you a solid answer, but I can say that you know, you very well may need a fusion. If you got a herniated disc pushing on a nerve and it's weak and everything else looks good, you probably don't need a fusion for that. So I'd say it just depends on what the films say.
Okay. Let's see. How old can a person be to go through a corrective surgery?
So that all depends. I mean, again, I have operated on 80-year-olds before. The big deformities, I shy away from that. Usually in your 70s, that's where you are with that. Anything 80s or 90s, I don't recommend a big scoliosis surgery for. But I've done laminectomies in early 90s, late 80s. I've done, a single level lammies. I've done minimally invasive T lifts in 70-year-olds, 80-year-olds. They do typically very well if they have good bone. So I'd say for a corrective surgery, it would depend on what corrective surgery we're talking about. A big one, I'd say early to mid 70s. I'd say for anything else, way early 90s to 80s would be the max, I'd say.
Okay. That's pretty promising, though, in my opinion.
Yeah, again, I do minimally invasive surgery. My one level fusions, I typically take an hour on, hour and a half in the room, on the table. So that I have a system that's really slick that does it really fast and effective. Minimally invasive surgery is, really come a long way. We're not talking 4 or 5 hour big blood loss surgeries here. So typically they're well tolerated and people stay a day or two in the hospital. They're out. It's almost like, hip replacements now. They're a lot faster. These are the simple ones, so very promising.
I like the thought that spine surgery could be classified as simple.
Yeah, I mean, I shouldn't say simple, but like,
As simple as it gets.
yes, yeah, more simple than it was at least.
Okay. So, this person's asking, can surgery correct the flat back I've had since the fusion for scoliosis 20 years ago? I am leaning forward more and more.
Yeah, absolutely it can. So now in a setting of a fused back for scoliosis long ago, if you have now again, my workup for this is I would get you a standing scoliosis X-ray, CAT scan, et cetera, et cetera. CAT scan would show what's fused and what isn't. If you have mobile segments there that they didn't fuse before, especially low, those are really useful because we can go in there and jack them open, get a lot of correction at one level without having to do a morbid procedure. But if everything is sort of fused up and down flat, and now you're looking at kind of a pedicle subtraction osteotomy procedure or something like that, where you go in and break up bone and move down, or again, there's other ways we could go about it, more simple, but in general, it's kind of what you're looking at there to kind of go in there, and it depends on what the picture shows, though, how much correction you need. Like if you're only a little bit out of balance, you only need a few degrees or 10 degrees or whatever. Usually we can go into one level and do that. If you have a mismatch of 40 degrees or something like that, usually that's like an osteotomy or something like that. But it is, depending on age and comorbidities, fixable. Um, you know, and we do a lot of that stuff.
Okay. If you have spondylolisthesis, I'm not sure if I said that correctly, should you try PT before fusion?
Yes, absolutely. Unless there's a weakness. Unless there's nerve injury. So if you have a foot drop or something that's new, or like a palsy or a paralysis or something like that, then surgery should be immediate. If it's just back pain or just back pain and radiculopathy, meaning like pain down the leg, try PT first. Try to core strengthen your core. The stronger your core is, the less that body's going to move on itself when you're bearing weight. And so a lot of times you can get through, give yourself a couple more years before surgery. You want to put the surgery off as long as you possibly can, age-wise. Getting a fusion at 4 or 5 when you're 80 or 70 is a lot different than when you're 20. It's more mileage on the spine when you're 20. So you're much higher risk of developing adjacent problems when you're 20 rather than when you're 70 or 60. So you want to put that off as long as you can. But if you can't do PT because you're in so much terrible pain, nothing works, then I would have surgery. But I would at least try it.
Okay. Are low blood platelets a comorbidity?
Yes. Yeah, we go for about 100 count. So anything below that, they won't put you to sleep for. You got to get fixed. Depends on how low the platelets are. If they run low, but they're above a certain level, that's no problem. If your platelets are like 10, yeah, that's a big problem. Won't do surgery.
Okay. And is that something?
It depends on what the level is. So,
Okay. All right. And you mentioned a nerve block. What exactly is that?
so a lot of different kinds of nerve blocks. So there's an epidural. So basically, like a pregnant person would have giving birth. So the catheter goes sort of, the needle goes around, centrally around the spine, the middle of the canal, like right in the middle. And they do at one or two levels a bolus of lidocaine plus usually a steroid. And they deliver that right on the nerves, okay, up and down. And that sort of gives you a nice block of the whole canal, a general block of a lot of nerves together. I love ordering selective nerve root blocks for people that have unilateral leg pain in a certain area. So say that I see something at L5S1, but your pain isn't quite the S1 level. It's more like in the big toe or something. Then I'll have the doctor go along these individual nerve roots themselves outside the spine here, and I'll block the left L5 nerve root, I'll say, only. That's going to give you relief in one dermatome, one area of your leg. And I'm going to see how much relief you get from that. It's more targeted. And then I'll say, okay, if you get relief from that, then I'm going to go right in that nerve root, decompress it, and that's it. So that's another kind of block. So typically they're in the lumbar spine, there's epidurals and there's transforaminals. Those are the big two. There's also for facet mediated pain, so pain in the back here. If the facets are bad, there's medial branch blocks. So there's a little nerve that comes off the dorsal horn here and goes to this joint. They can go in there and either inject it or radio frequency ablate it, RFA, and they burn that nerve away. Then this nerve will eventually grow back, but it takes months to do that. So it can relieve pain that's in the back. Those are better for back pain, less so much for radiculopathy. So an RFA wouldn't help leg pain; they mainly help back pain. So those are more sort of mediated, facet mediated or joint mediated pain. And there's other ones they can kind of do, but those are the big three I would say that are in the back.
Okay. What can you do for multiple compression fractures up and down the spine? So it looks like somebody is experiencing that with some issues from soft bone from myeloma. And this person's been taking different medications and trying different treatments, but is in a lot of pain. Is there anything you can do for multiple fractures like that?
So myeloma is tough because I don't think that bone building drugs such as Prolia are indicated because they can kind of worsen the myeloma. They're like, growth factors. You don't want to encourage growth of tumors. So with other extraneous drugs. So those may be a problem to build bone. Myeloma is treatable typically at painful areas by osteocool ablation. That is a special technique. I do that. Pain doctors do that. Interventionalists do that. So, osteocool ablation involves going into like a kyphoplasty, going into a certain vertebral body with two needles, turning the machine on, letting the heat there basically burn away whatever tumors in the vertebral body, and then filling the cavity with cement. It's like a modified kyphoplasty. You can do them at every level, pretty much from T5 down. Anything above that, you can't do. But there's people that do that all the time. So I'd say if you're a good candidate for osteocool ablation, that would be a good treatment for that.
Okay. This person had a spinal decompression surgery, but is still in a lot of pain. Is there anything that can be done?
Depends on when it was. So if it was a laminectomy, so if it was done recently, I'd say expect some pain for a while. If it's years out or months out, I'd say, is it back pain? Is it leg pain? Is it both? What pain are you currently in? That's sort of an issue. Now, if you have, there's another question on here. So 4.5 weeks ago, this person on here had a L2 to L5 fusion and still has some nerve pain. That's expected. I would say that's pretty normal. 4.5 weeks, about a month out. It's common to have some nerve pain at that point. I would keep an eye on it, treat it, give some steroids, local injections, some time. Sometimes your nerves just need time to adjust. If after 2, 3 months, 4 months, things start to happen, if it's worsening pain, may choose to get an EMG study, may choose to get another film, see what's going on. But right now, I'd say within a month, it's okay. Further out, it should be better by now. So, by months out, if it's still there, might be worth looking into with more studies to see what's going on.
Okay. This person had a laminectomy of L5 due to a tumor on the spinal cord. So they're having some lower back pain and hip and leg pain after that surgery. And they can't walk any distance. Only relief is lying down. Or is there anything that can be done for them?
Again, gotta look at the study. So it depends, number one, what the tumor was. Okay, so benign nerve sheath tumor, schwannoma, for example? Was it an ependymoma, something a little more malignant? Not malignant, but a little more, can spread or recur. I mean, ependymoma is a benign tumor, but it tends to grow fast. Meningioma, something like that, or was it, what tumor was it? Number one, a MET, who knows? Number one, number two, what do the films look like? If the surgery itself was successful in removing the tumor, but induced a deformity or destabilized the spine, then yeah, more surgery can help with that. That's causing pain. If you have underlying degenerative changes that were on top of the tumor that just went sort of untreated because the guy was focusing on the tumor, more surgery may be indicated. All will depend on that point on what the films show and the presentation.
Okay. I'm cruising through here to see if there are a few that are. Okay, this one's interesting. So this person had a T4-5 compression fracture at 17. Now they're in their 70s and pain is starting up. Is that something that can be addressed?
T45 is too high for kyphoplasty if it's a fracture. So again, now we're talking, 60 years separating. New film, new MRI of the thoracic spine, I would say, to see what's going on in there. If it's something that's amenable to a fusion procedure, possibly. Um, if there's just decompensation at that level or kyphosis or something like that, could be amenable to it. Or a refracture or something below it. If there's a new fracture below it, absolutely, we can do something about that. Anything below T5, if it is a compression fracture due to osteoporosis, kyphoplasty is a great procedure. I would say it's worth getting an MRI and taking a look.
Okay. Can Tarlov cysts be the cause of bilateral pain in the low back, buttocks, and legs?
No, simple answer.
Okay, that's an easy one.
There's a mantra among spine surgeons: never the Tarlov cyst. Um, so I've seen a lot of them in my practice, in fellowship and residency training. No surgeons I've ever seen have operated on them. They're
Okay.
benign cysts that are in the sacrum that do not cause problems. Again, there's
Okay.
some surgeons out there that say I'm crazy, So I mean, there are people that maybe do Tarlov cysts a lot. I see a lot of them, and almost always I find something else that's causing the problem that's not the cyst. That was overlooked. A lateral disc, a far lateral disc, or something like that, or instability nobody's looking for. That really is the cause of it. And the Tarlov cyst is a red herring. Now, again, again, this is my opinion. It's what I've been taught in my fellowship, is what I'm taught in residency. Not necessarily, people do operate on Tarlov cysts all the time. Results of it are shaky. So I would say the answer to that is no.
Okay. Um, okay. You talked a little bit about the stay following a surgery, maybe a night or two in the hospital. How long is recovery time to go back to work for this person specifically asking about spinal stenosis, but is there like an average amount of time that your patients will spend off of work?
For a laminectomy for spinal stenosis, 2 weeks typically.
Okay.
When the wound heals, you can go back to work. Especially, I mean, because you're not going into disc space, you're not fusing, you're not destabilizing anything. You're just removing bone you really don't need. So as long as the wound is healed, skin is healed, you can go back to work. I would say you want to avoid, like work, I'd say a desk job or something like that. I would avoid heavy manual labor for a good period of maybe a month or two after a surgery like that, because you don't want to like rip muscles apart. I mean, it is sewn together. I'd wait for those muscles to scar up nicely, 3 months maximum. I'd say a good 1 to 2 months is probably good. If you're doing heavy lifting or bending or twisting or torque, like twisting or something like that, I'd say you want to wait a little longer. Something like a fusion, 3 months for heavy activity. Um, Something like a discectomy, same. 2 weeks, you can go back to work at a desk job, no bending, lifting, or twisting, or anything greater than 10 pounds for a good 2, 3 months, I'd say.
Okay. Okay, this person had a pelvic fracture on the right side a few years ago, had therapy and pain subsided. Now they're getting very low back pain on the right side. Could there be a relation between the two?
Could be pelvic fractures are an ortho thing, not neuro. But it could be related, could be unrelated. Need films to kind of see what's going on there. The pelvis heals pretty nicely, so could be related or could not be. Depends.
Okay. And when you do have a surgical correction for spinal stenosis, how long can you expect that to last?
It lasts forever at that level because the bone
Oh,
doesn't grow back.
okay.
So if you have true spinal stenosis due to ligament thickening and bony impingement, you're removing the ligament and the bone in the back. It does not grow back. So that canal is open forever. So you will not get recurrence of stenosis at that level. Now, again, if you do one or two levels, you may develop it above at the unoperated on level. So it may recur at a different level, but at those levels you operate on, it never recurs.
Okay. Okay, so this person is saying last fall they had an SI joint fusion that did not fuse. Should those screws be removed?
I do some SI fusions. Boy, those are tough if they don't fuse. I would ask if they're in pain. So if they're in active pain and there's signs of loosening, that sort of thing, then options are to go back in there and replace them with bigger screws, try to get them to fuse a little bit. Um, I would say I wouldn't just leave that. I'd say probably yes, you want to try something to help with that. Um, Again, I don't know if I really wouldn't I wouldn't hesitate to go back in there and try to get them out if they're loose. If there's show signs in the CAT scan of like loosening up or breaking, they're going to be awfully hard to remove. But it's possible. So I would say, and the simple answer to that is yes, it's worth reoperating.
Okay. It's definitely worth coming in and getting looked at, it sounds like.
I think so. I can't guarantee that I would do it, but it depends on what I see there. Knock on wood, I haven't had a failure with my SI joint fusions yet, so I haven't had someone come back and say it failed because it heals pretty nicely, but you never know. We can try.
Okay. Are there any downsides of a nerve block?
Oh yeah, if they stab your nerve root, which is rare, or if they get a CSF leak, you get a spinal headache for an epidural. Um,
Sounds
there was
awful.
that debacle over that the while ago that dirty drug they were doing, they were giving meningitis. That's unheard of nowadays.
Okay.
This was decades ago. But I'd say CSF leak and spinal headache, and if they happen to touch the nerve with a needle, but that's really rare, honestly. The guys I use personally are really good. It's pretty safe stuff. It's all under X-ray. It's well tolerated. There's minimal drawbacks to it.
Okay. I'm just trying to scroll through and see what I can. Okay, so someone has scoliosis and degenerative discs with severe facet arthritis. What can be done with that possibly?
So I'm assuming back pain with that, so scoliosis, degenerative scoliosis, we start with the basic films, MRI, CAT scan, and a standing X-ray. If there's global imbalance, you know, um, and you haven't had surgery before, that's corrected usually with a multi-level interbody fusion. So, again, we're talking about facet joints, a deformity, plus or minus radiculopathy, because that can really impinge on nerves too. So usually it's back pain and leg pain. Going in several levels and doing like a corrective surgery, such as a multi-level fusion, restoring normal lumbar lordosis, getting it back in line can go a long way to helping. If you had previous fusion, it can be a little more complicated depending on what we're talking about. So it would start with a workup, MRI, CAT scan, and X-ray, scoliosis X-ray, and then from there I measure my angles and see, what we need, and then I see what we have in my toolbox to help, and I pick the simplest thing possible, the least amount of surgery possible, and then it kind of goes from there.
Okay. This person's saying they had a failed S1 through L3 fusion. Their surgeon's recommending repeating that surgery with better hardware, more robust hardware. And a second opinion says do not take the hardware out. Do you have an opinion on that? And have you ever done something like that?
Answer: Yes, I have done a lot. I get a lot of uh, you know, second opinion type things. So yes, I have removed hardware and replaced it. One guy says yes, one guy says no. That's puzzling. I get a third opinion because um, if there's loose or broken hardware in there, unequivocally something failed and something needs to be redone. If the hardware is robust and looks normal, then the guy that wants to redo it is what do they want to do? If you're already fused, just putting more robust hardware in there to replace good hardware is not going to help you. So one of two things is happening. There's a global imbalance, so pelvic parameters are off. That's why you're not happy. Or hardware failed, and I'm not looking at films here, so I don't know. Well, the hardware failed. There's loosening. There's lucency. Broken hardware, or it's misplaced, or something like that, or both. Um, I'll never know till I see the X-ray. So I would want to definitely take a look at that X-ray and CAT scan and see what those guys are looking at. Because one guy says don't remove it, one guy says do remove it. That is unusual. If one guy says I'm going to remove it and do X, and the other says I'm going to remove it and do Y, that's more acceptable because both agree something's got to be done. One guy says don't touch it, the other guy says touch it. That's more odd. So it's time for a third opinion.
Okay, tiebreaker.
Yeah,
Okay. Next one, and I should acknowledge we are a few minutes over here, Dr. Francis. Are you okay to answer a couple more
I'm
questions?
fine. Yeah, I'm not going anywhere.
Okay. Okay. This person had a spine fracture T8 vertebrae 3 years ago. They've tried shots, ablation, nerve stimulation, and lots of drugs. The latest drugs are helping, but make them very tired and balance issues. I'm sure there are lots of side effects that come with some of these drugs. Lots of people are telling them don't have surgery, but the biggest issue is pain after walking for a short period or just standing. Do you have suggestions on if something can be done to help this person?
So a T8 fracture could be a lot of things, a compression fracture or something worse. If there's instability at that level, like a facet fracture, definitely something can be done for that. A compression fracture. So, thoracic spine surgery like that for a fracture to try to go in there and reconstruct the anterior column, that's a big surgery. Usually involves a rib takedown. To get into the chest like that's tough, but not impossible. So if there's like a segmental, kyphosis, malalignment due to a fracture, horrific pain. The key is to get in there in the front, take the disc above and the disc below out of there, and the bone intervening, whatever's fractured. Put an expandable cylinder cage in there to take the place of what that body did. Fill that with bone. Put screws in the back and call it. That's it. That is highly effective at treating problems and can treat your back pain. The good thing is the rib cage itself is the thoracic spine is inherently very stable due to the rib cage. So something like T8 is encased in ribs, which, as opposed to your lumbar spine, which kind of hangs free, only muscles support that. I mean, you got muscles and ribs and sternum bracing you. So those are typically very stable, situations. So despite the morbidity of the approach, which isn't that bad, I use a thoracic surgeon to help me expose that. And I go in there and just kind of just take down the disc above and below, scrape them clean, put an expandable cage in there, screws in the back, pretty straightforward. Not
Okay,
that bad, really.
just like that. Okay, sounds like another opportunity to get an opinion or a second opinion
Yeah,
from
if you've got decent anterior column support, if it's a little fracture and you still have bone left, maybe just a posterior instrumentation may do it. Just a posterior fixation, lay some bone across the back, fuse that segment together. That might be all you need. Depends on what the X-ray shows. I mean, I need a big thoracotomy, depends.
Sure. Okay. So 23 years following an L5 laminectomy, they're having pain in the higher levels of the spine. Is that something that qualifies for a repair?
So pain above a previous LAMI would depend. I would say, do you have another MRI? Any adjacent level degeneration and there's back pain up there? May. Um, it may be just the fact that there's L5S1 changes from the LAMI that you're feeling higher up in the spine. The pain in the low back can fool you. Just central low back pain. Oh, I've got pain at L4. Well, you don't know where the pain is typically. I mean, it could be L5. It's just next to it. So again, you don't know if it's pain significantly higher, like maybe thoracic or mid back. That might be something different altogether. So that would depend on kind of where it was related to L5, number one. Number two, what the MRI showed. But I think it's worth working up.
Okay. Um, After my spinal revision surgery, T10 through S1, it feels like my legs are not aligned under my body. Left hip hurts, right hip is slight pain, and it's difficult to put weight on the left leg. Is there hope to be able to walk again without a walker?
Yeah. So basically, you know, that would um, that would depend on what the scoliosis images show. So if you've got a pelvic tilt due to a coronal deformity, um, straightening the spine out in that situation may help. If it's more of an orthopedic problem, meaning like you got a leg length discrepancy or a hip issue, that is something I don't treat, but something that I mean, for instance, may cause a little bit of imbalance there. Um, It would depend on, my workup for that would be sort of a X-ray, a big X-ray, scoliosis X-ray to see what the numbers show. And if coronally you're in balance, I'd say I'd send you to an orthopod to do a leg length measurement and that sort of thing and see if there's a discrepancy there. So it's a tough question there. I mean, I think there would be hope, but it sounds like you need to be worked up.
Okay. This is a question around complex PTSD. Are spine surgeons trained in that? And the negative changes to the nervous system and the negative impacts on health. Is that something that a person with PTSD can expect their surgeon to have some training in?
Surgeons are trained to recognize it for sure. Now, we aren't trained to treat it by any means. We're not psychiatrists, or neuropsychologists. So that would be a typical referral we would do. But if a patient comes in with that, certainly I would want to make sure if we were planning surgery for that patient to make sure our ducks are in a row and you're getting treated for it. We are trained to sort of appreciate it and recognize it, but we aren't specifically trained in management of it.
Okay. All right. Is it unusual to have persistent mid-back pain 2 years after a compression fracture due to osteoporosis? And it looks like they had a treatment, I'm not sure how to say, kyphosis,
Uh, ky- uh,
kyphosis, and
with
then there's
kyphosis, yeah. So
oh,
yes, yeah, that is typical. So no improvement in physical therapy. So segmental kyphosis like that can be painful in the thoracic spine. That's what we were talking about before. So if there's an anterior column obstruction, there's a lot of kyphosis there. There could be a refracture in there. It's tough. It depends on what it looks like. If there's sometimes the body compresses so much, it's almost nothing left there. Um, the big question there is what do you do for it? So that's a reconstructive kind of surgery. We see if you lay down, if it reduces. Now again, you got osteoporosis. So the most important thing you can do right now is make sure you're getting treated for it with something like teriparatide or Forteo if you're a candidate, so you don't get more of this. Um, Trying to correct this surgically, we got to be careful because you're osteoporotic. So now we're putting screws in. Now, what are we putting screws in? Are we going one or two levels above? Is the bone quality good enough to hold a screw? Is it amenable to surgery? It depends on how bad the osteoporosis is. If it's happened 2 years ago and you've been treated since, but you have a deformity there, but your bone quality is really good due to treatment, I'd say, yeah, it's something we could do for you. Depends on, again, how big of a surgery we want to talk about, how much bigger surgery you need. We could do an MRI and you could have a refracture in there too. It could refracture as well if your osteoporosis is bad enough. So all depends. But yeah, I think, it's worth working up for sure.
Can you talk a little bit about the difference between a CT scan and an MRI and which one is better imaging for the back?
Yeah, so both are equally good, and they do different things. The MRI is magnetic based, so there's no X-ray. So it is good for people that have, even if you have surgical metal, usually it's okay. Any foreign metal bodies you have in there, or any like spinal cord stimulators that aren't compatible with the MRI, or pacemakers, for instance, you wouldn't be a candidate for the MRI. MRIs are great for providing details. So I don't know if you guys can still see my slides. Um, you know, Let me end here. This here on the left side is an MRI. So you're seeing great detail here. Discs to the T, white, black, white stripes, nerve roots, individual nerve roots. You're able to pinpoint with an MRI. This is a T2 weighted MRI signal. Great anatomy here, right? Bone quality, well, it's decent, but it's not great, right? I mean, you can see the bone, but trying to look at the bone to decipher fractures in there or subtle fractures, it's not as good. Say, come over here to the right. This is a CAT scan. Okay, it's X-ray based, a lot quicker to do. Everybody's safe for it. If you can't, not a candidate for an MRI, we can do a myelogram, CT myelogram, where they give you dye in here. CAT scan's great for bones. See, it lights bone up like crazy. So fractures light up like a Christmas tree. Previous, fusions are really discernible here, whereas here on an MRI, you might not be able to see it that well. Um, so, see if I can give you an example of that in here. Yeah, here's your MRI with hardware. See the artifact? It looks like just a black spot. Here is this fused? Who can tell? This on the left side here. You can see a disc herniation really well up here, but here's an MRI. Like I can't see if that's fused or not. I can guess. Maybe it is. But then you get a CT scan or an X-ray, boy, you really see the implant very nicely in those. You can tell what's fused and what's not on, say, an X-ray or better yet, a CAT scan right here, where you can see, oh, look, there's bony subsidence there. There's no metal dropout. I see the metal exactly. I can see hollowed out screws on a CAT scan right here. That's the difference, basically. So I tend to get CAT scans in people with previous hardware in there because it really lights the hardware up nicely. Whereas a MRI, it's like a black spot. I can't tell if it's loose on an MRI, for instance. So it just varies, depends on what you need. But they're two very different studies.
And so it wouldn't be uncommon though for a spine surgeon to have you have both studies done so that they can.
Yeah, will not be uncommon. I do it all the time.
Okay.
They're two completely different studies.
Okay. This person had decompression surgery on lower back over a year ago, and now pain is going up the back on both sides. Anything that can be done for that?
Let's see. So decompression low, pain going up the back. Again, tough for me to say. Got to look at the MRI. I don't know. Maybe. That's a very non-specific kind of thing. So I would see if, hey, for instance, you got some problems up top, like bad discs up top. Yeah, that could be explanation for it. Everything looks good. I'd say, well, just hit some physical therapy and pain management and go from there. Hard to say. I'd have to see the films. I don't know.
Okay. I think this is an interesting question because when you show that imaging, it really does look uncomfortable. Can you feel or bend when you bend or sit, can you feel the all that hardware inside your spine?
Most people can't because there is a nice padding of soft tissue between the hardware and your back skin. Now, this person here on this picture, absolutely, they can feel it. That rod's probably going to come through the skin on this person right down here, bottom left. I mean, this person can definitely feel their hardware. People that are really thin and have cervical hardware, they can palpate because there's been muscle wasting over the back. Yeah, they can feel their hardware. But typically, people that just have surgery, it's way in there. It's buried under, inches of muscle and fat and skin. So typically, no, you shouldn't be able to feel your hardware.
Okay.
If it backs out or like this, if it breaks and pulls out, yeah, you might be able to feel it.
Okay. Okay. Okay, so can a CT scan, we're just going to have a follow-up question to the CT versus MRI. So can a CT scan miss a disc bulging on the C spine?
Absolutely, it can. A CT?
Yes.
Yes, yes, it can
Okay.
because it doesn't show discs very well. Here, look.
Okay.
Here's a good, this picture here, bottom right. Here's a CT scan. Can you see disc? Yeah, we can see it there maybe a little bit. Is it great compared to that? On an MRI? Yeah. MRI is way more specific for discs. CAT
So
scan can catch it. MRI is way better.
is it reasonable for a patient? So if their surgeon orders one type of imaging and maybe doesn't find anything, is it reasonable for the patient to ask for the other as well?
Absolutely. You should ask your surgeon anything that's on your mind. Sure. Yeah, but if like for instance, within, I mean, again, ask away, but an MRI doesn't show a disc herniation. A CAT scan is not going to help you, right? An MRI doesn't show pseudoarthrosis. A CAT scan may very much help you because it may show loose hardware or broken hardware where an MRI won't. So it all depends on what you're looking for. Yeah. So if you had a fusion, guy does an MRI and says you're fine, I'd be like, well, you know, what about a CAT scan? You can't see the hardware, right? It's all black and dropped out. So how do you know I'm fused? I mean, again, yeah, CAT scan would really show that. Um, yeah. So it depends on what you're looking for.
Okay. So this person had a spinal fusion for spinal stenosis, minimally invasive 3 years ago. It helped, but the pain came back worse than ever after open heart surgery. So that was a couple years after. And everything appears to be intact by imaging, but pain is in the lower back, buttocks, and back of thighs, and the lower legs, they say. And
So,
yeah,
so that speaks to me of imbalance, like pain in the legs, like, so every time like you're trying to compensate for a global imbalance, you're moving your legs in a way to kind of bring your head back. So any kind of aching in the legs or something like that usually is a result of you trying to contort your body in a certain way to fight what was done. Um, Ultimately, all these questions like kind of hinge around what is your, me interpreting your films, like seeing, and I can know right when I look at it, so you're getting the proper films, like just measuring balances, global balances, seeing what's fused, what's not fused, you know, all these questions like, can anything be done for it? All depends kind of on what I see if I can fix. Now, for instance, I mean, if you got global imbalance in there, you're positive 20 centimeters on your SVA, you're tilting your pelvis like crazy. Yeah, something can be done for that. If everything checks out with excellent lumbar lordosis, no pelvic mismatch, screws, rods look fine, surgery looks fine, whatever, that person like, well, I really can't help you. We got to look for something else at that point. So I say that's the big difference.
Okay. So I'm kind of cruising through. There are a lot of questions that are very specific about patient situations, but I'm guessing it's going to be similar answers of you would need to see in the films and kind of see what's been done and what's happening in there. Does that sound reasonable?
Yeah, so I can scroll through a lot
Yeah,
of
if you
them
want to
here.
do that, that'd
So
be great. And I'll just
yeah.
say while you're scrolling that we will include contact information for your practice, which is in Pontiac on the campus of Oakland Hospital. And we
Yes, I also I did open up a clinic in Livonia at the LMC every other Thursday
Okay,
as well.
I was just gonna say that. So perfect. So are you in the hospital there as well?
I'm in the clinic at the LMC only. I do all my surgeries at Oakland.
All right, perfect. All right, so you are on the campus of Schoolcraft College then as well. So that's two locations that are like really central, I would say. So Oakland at Oakland Hospital, and then Schoolcraft campus, which is in Livonia. We also have neurosurgeons in Ann Arbor and kind of in the West area as well. So I will include contact information for all of those locations, but especially Dr. Francis, if you are interested in having a second or third opinion in some cases.
Yeah, I'm happy to see anybody here. I can answer these questions online if you'd like me to as well. Just I can just type in answers here, or is that okay? Or yeah,
Yeah, if you want, if there are a couple you want to call out loud, that'd be great.
yeah. So one. I got a question. I had back surgery last month. Now I have to do a fusion. Don't know if I can go through with it. All it would depend on what the films show, I would say. Um, it would all depend kind of on if you got ongoing problems versus like, do you need a fusion? That's the big section that I have. Do you have a spondy? Do you have instability? Do you have a deformity? Do you have, two microdiscectomies in the past? Now you got a third one pending. Might need a fusion. So it depends. And fusions can't, I don't want to say they're as scary as they may be. I mean, again, a one level fusion isn't as terrible as it used to be. If you need it, you need it, I would say. So that person, I'd say, all depends on what you got there. Okay. Um, so 65-year-old osteoporosis, no pain, spondylolysis, L5S1, recommending fusion. So my first question would be, why are we recommending fusion? If we have, no pain. So I read again, weakness, numbness, intermittent, better with movement. I'd say what's weak precisely? Pain in a dysfunctional motion segment should not improve with motion. It should be worse with motion. So a lot of contradictory things here that I'm seeing. So osteoporotic, number one, I'd say I get your bone health under control before surgery is considered. No pain in the back. I wouldn't consider a fusion unless you really needed it. Numbness and weakness, I'd say, what is it? Intermittent weakness is sort of strange because weakness usually is permanent. Um, and better with movement is contradictory to me in terms of like you needing a fusion. If I just read this little snippet here, I'd say you don't need a fusion. I would want to look at your films and be sure about that. But this person, I would say, probably doesn't need a fusion. Okay. Um, Pseudomonas infection following massive spinal surgery. That's an infectious disease question, not mine. So I would defer to an infectious disease specialist on that. But I would say this, if they think this hardware is seeded with infection, it should all be removed because it can just be a source of recurrent infections. That's up to the wound care specialist, usually the ID doctor and your surgeon. So if you have an infection, a wound infection that recurs, nobody knows why, it's refractory to IV medication long term, you're definitely going to want to have that hardware removed. Okay. That's one thing. So, partially fused lumbosacral transitional vertebrae. Okay. So, a lot of this depends on what your study shows. There's something called Bertolotti syndrome, which is like this transitional large transverse process that impinges nerves. Resection of that can help. Um, so, if it's partially fused transitional vertebrae, usually the level above that, is the problem. You had a multi-level discectomy here back in the early 2000s, and SI joint issues as well. So the problem here is back spasms. My studies, I would order flexion extension X-ray and an MRI lumbar to kind of take a look at what's going on. If you have a lot of degenerative changes down there, and your back spasms and your back pain is significant enough to warrant surgery, you may be a candidate for a fusion at that point. All depend on what your studies show. I know I'm starting to sound like a broken record. Um, Low back pain, physical therapy, injections, ablations. Okay, not time for surgery. Okay. Deadening of nerves down the leg, inversion table. Great. You're fighting the good fight right there. Okay. So yes, that is I don't know, can I call out names? Maybe make it easier.
Maybe initials.
Okay. Okay. BM, I would say that that's you're on the right path there. Um, you're fighting the good fight there. And eventually, it may need surgery, but all the stuff you're mentioning is very good. So I would say yes. Okay, 8K. I had spinal fusion L3 to L5 for spinal stenosis and spondylolisthesis. So 3 to 5 fusion. Okay, 3 years ago. It really helped. That's great. Pain came back after open heart surgery. Okay. Um, Everything is intact by imaging. Okay, so pain is in the lower back buttocks. Okay, so um, everything is intact by imaging. Okay, so is global sagittal balance okay? And is the L5S1 disc okay? Are my big questions on that. If those check out, I'd say, yeah, I mean, surgery, more surgery. If everything checks out at that point, surgery was not going to help you much. If you have pain shooting down the legs in an anatomic distribution, backs of thighs tells me it's S1, which is that bottom level, maybe subject to adjacent segment degeneration. You never know. I think it's worth another look as long as we have the proper studies there. So I would say I'd see the MRI and the pelvic parameters and see how they check out. BH has nerve pain, center of the right foot. 4 to 1 fusion, low back fusion, neck fusion, 2016. Yeah, for neck surgery. Okay, so center of the right foot, if it's more towards the top, could be L5, bottom more S1. Everything's been fused anyway through those. I'm imagining all these were quite a while ago, 08, 16. Imagining all the previous CTs you've had have checked out, nothing's failed. It's kind of odd. I would recommend for you an EMG unless you had it, for sure. If there's weird symptoms like this, the middle of my back hurts, middle of my foot hurts, down the legs, sciatic possibly, I would get an EMG and see what the EMG shows. Probably maybe if you already had one, but that would be my next step for you, to get a nerve conduction study down the leg and see what happens there. So, you know, EMG is a electromyography. It's a great study. It can tell me exactly, okay, L5S1, you know, um, is, chronic denervation, is previously denervated but is recovering or is ongoing. It's very specific, actually. And if it's done right, it can really help. So, you know, um, okay, let me see. Second here. So, next question is Evenity an option for a failed fusion? And Evenity, much like most bone building drugs, this is from ST, it can help build bone to stabilize fusions, to help with bone growth, but it won't help with pseudoarthrosis, for instance. So if it's pseudoarthrosis, that's got to be surgically fixed usually. Evenity can be a good adjunct in case you have osteoporosis and the fixing part is failing because of bad bone, or if it because bad bone caused this, Evenity or something similar can be really helpful in that. Um, so for a failed fusion, it's a good adjunct, but eventually something's got to go in there, like a graft or a cage or cadaver bone, to get that going. You need the substrate to fuse the disc properly. So, you know, okay. Another question. Okay. Let's see here.
There's a question about radio frequency ablation and versus osteocool ablation. What's the difference?
Yeah, very different, very different. So, osteocool ablation goes in the bone. So it it's a for metastatic bone tumors. It's palliative treatment. It goes into like a kyphoplasty. 2 needles go into the bone. You give a dose of heat that just kills pretty much anything in the vertebral body itself, including the tumor. And then you just fill the area with cement. It's a bone surgery. Radiofrequency ablation, RFA is something that a pain doctor does. So they basically give you a heated dose of through a needle of a little nerve that goes out to the facet joint. So it's in the spine, like in the foramen there a little bit. That sort of burns the facet capsule, and it's for designed for back pain. It doesn't go in the bone; it just goes around it, and it's a nerve ablation. So those are two different things. One's for sort of a bone tumor, the other one's for back pain mediated by just a bad facet. So a couple different, yeah. Um, so let's see more questions here.
There is one comment I'll read out loud. It says, I had Dr. Francis lumbar fusion 3 years ago. Very successful and the best thing I had done for my pain. Thank you. So that's a
Oh, thank
comment.
you.
Yeah.
Good to hear that. Great. Good to hear that. Thank you very much. It's good to hear that. Very happy. Very happy. I love to, I get bothered when things go wrong. So it doesn't happen often, but I really want my patients to do well. That's why I kind of annoy them. I do a lot of workup, like extensive workup. So I'm darn sure if I'm going in there, we run a very good chance of helping you. Sometimes it doesn't, frankly. I mean, sometimes it just doesn't work that way. Um, it's certainly, something we try to avoid for sure. But I found in my practice, if you check a certain amount of boxes, I can all but guarantee you're going to get somewhat improved, and managing expectations is key. But in general, if you find that, you break it down to a certain area, I can treat certain things and not other things. So yeah. So
It sounds like anyone that comes in will at least walk away with some sort of next step as much as possible, right? So whether it's surgery or if you recommend some other course of treatment.
I'll certainly, yeah, guide the treatment in a certain area for sure. Like really, if if I if I see, whatever, when you come in to see me, I go over your films with you. So I'll show you what I'm looking at, CAT scan, MRI, whatever, give you all the treatment options, and then from there we can make a decision, what you want. And, you leave pretty, hopefully well informed about your condition and have some options in terms of where to go from there. I usually don't say, well, sorry, I can't help you. But, again, it's sort of one of these things where it all depends on what you come in with and what I can help with. So it all depends. Yeah.
Okay. Well, with that, we're about 40 minutes over, so I think we should let you go, Dr. Francis. You've given so much of your time and your expertise. I so appreciate you doing that. If you, I think, have gone through most of the detailed questions. If you see any other questions over the next few seconds here, just feel free to shout it out. I just wanted to repeat that we have recorded all of this. So those of you who are still hanging in there with us, you will receive an email in the next couple of days with a link to the recording. And again, we will share all contact information for Dr. Francis as well as his colleagues that are located throughout Southeast Michigan. And I see a question asking regarding a referral to get a consultation from him. Do you require a referral, Dr. Francis?
I don't myself, you know, but I mean, the insurance may, I don't know, but if you call my office, I'll see you. I don't need it personally. I mean, if you call the office, I want to see Dr. Francis, they'll usually get you an appointment.
Okay. And if it's something that your insurance requires a referral or you have any other sort of tape around it, red tape around getting in to see Dr. Francis, I'm sure that the people answering the phone will be really, really good resources for you and help you figure out everything you need so that you can come in and try to make it as painless as possible from that perspective.
Yeah, I mean, we don't want certainly, certainly to, make it as easy on you guys as possible. Sometimes, I try to see all my patients, but sometimes if you don't have updated films, it's faster to have my PAs get you in and see you, and they'll order all the films and the workup, and then you can come see me too. So don't worry if you don't see me at first, but you'll see me eventually once you're completely worked up. And sometimes, my PAs are too busy. I'll see you without films anyway. So it all depends on who you get. So don't worry if you don't get me at first. You may get my PA, but doesn't mean I don't care. I mean, all we're doing is just if you don't have updated films, we'll just they'll just order them quickly, get them done. You'll come back and see me. I'll tell you the kind of the same thing if I see if you don't have updated films, I'm gonna write you a script for them and we'll see you on follow up. But I'm happy to, I'm happy to see you as well whenever. So just don't be alarmed if you do see my PA. So
Okay, that's a good point. And if you do have any kind of imaging from, especially another health system or that might not be available for Dr. Francis and my chart, that'd be an important thing to bring with you to a first appointment.
yeah.